Perfect. A couple of introductory comments. First is I really would like to thank Crohn's and Colitis Canada for not only having us on the program tonight, but for also partnering with us in the SECURE-IBD program and helping to get the word out there. It's only by partnering with organizations like yours over the globe that we're able to ensure the success of this project. And I'd also like to thank Gil and Eric for personally inviting us to be here this evening. I've been friends with Gil and Eric for the last 15 years, which is hard to believe. And finally, I know that this organization is as patient-centered and spun off of patient motivation. SECURE-IBD is also spun off of patient motivation, and it was on March 5th that I got a text from the parent of one of my patients saying, Dr. Kappelman, what are you and your team doing to study COVID in IBD patients? And I had absolutely no answer to that question on March 5th when I got the text. But it was only about 12 hours later when I woke up at 3 in the morning and realized, gosh, we really do need to study this. We really do need to study it quickly. And the only way to do that is to put together a worldwide collaborative project that includes both pediatric and adult IBD, and where the entire world can work together to solve this problem as quickly as possible. So with that in mind, I'm really happy to share our preliminary data. These are data that are hot off the press as of yesterday. It's quite astonishing that we have had over 700 reported cases of COVID amongst IBD patients, and perhaps even more astonishing that reports have come from a total of 38 different countries. The median age of reported cases is 41 years. 53% of cases reported have occurred in males. And at the bottom of the slide here is a breakdown of the inflammatory bowel disease activity at the time that COVID was developed. Close to 60% of patients were in remission. In other words, their IBD was quiescent and there were no active symptoms. 18% had mild IBD, 14% moderate to severe IBD, and 6% of reported cases were unknown. Let me see if I can advance my slide. So this is a map that Gil Kappelman and his group produced for us, showing graphically the countries who have reported cases. And I'm going to actually use this as an example. Probably the most amazing thing about this project is that, and actually about the entire COVID epidemic or pandemic, is that it really has restored my faith in humanity. People have come out of the woodworks approaching us with offers to help. What can I do to help? How can I help analyze the data? Is there anything that I can do to help get the word out there? And Gil and his group came to us and said, hey, we've looked at the data that you all have been reporting online in your registry, and we've put together a interactive map for you, modeled after the map that Gil had shown earlier and that the Johns Hopkins group is using to show the worldwide spread of COVID. And after that gift from Gil's, we've included him and his team as a partner in helping us with data visualization. And we'll talk a little bit more about that later today. This next slide here, if I'm able to advance, is another representation of the number of cases by country. And what we're seeing in our case reports roughly mirrors the data that Gil had shown earlier this evening in terms of the worldwide impact of COVID-19 and how there's about 10 countries or so who have really been hit hard. And we're seeing exactly the same thing in our data. Let me see if I can And so this is our curve of cases reported over time. The orange at the top are cases reported in Crohn's disease patients, and the yellow at the bottom are cases reported in ulcerative colitis patients. Unfortunately, it's been a linear, if not parabolic, increase over the last several weeks since the beginning of really the beginning of time on March 13th. So I'm going to get into some of our data as well. This summary slide here is busy, so I'm going to take a little bit of time and orient you. At the very top of the slide here is our overall population of 704 reported cases. 67% of reported cases amongst IBD patients have been relatively mild and have been managed as a outpatient only. Roughly a third of cases of COVID have required hospitalization, and the death rate amongst our reported cases is 4%. So that's roughly along the same lines of what Dr. Kappelman showed on the Canadian data, and really roughly along the same lines of what we've seen worldwide with COVID. So I think the most important message that we've learned already is that when COVID happens in IBD patients, yes, for sure, it's scary, but it is a lot better than many of us would have predicted in early March. I think the other take-home point is, like with the general population, the severe outcomes of COVID, and particularly death, seems to increase with increasing age. So you can see at the bottom here, we've had no deaths reported in not only pediatric patients, but patients less than 30 years of age. Conversely, for patients with inflammatory bowel disease who develop COVID that are reported to our registry, in the older age group, the death rate is as high as 33%, and about 3/4 of the deaths reported in our registry have occurred in patients greater than 60 years of age. So it seems like age is the major driver of COVID-related severity amongst IBD patients, much the same as it is in patients in the general population. In addition to age, another major driver of COVID outcomes are non-IBD comorbidities, other health conditions beyond the inflammatory bowel disease. You can see here again in patients with IBD only and no other comorbidities, the death rate is about 1%. And as the number of comorbid or other health conditions increases, the rate of death in IBD patients also increases. The million-dollar question, of course, is how do medications affect the outcomes of COVID? And we do have a lot of data that is posted on our website, but rather than showing you numbers, what I thought I would do on this slide is provide some high-level trends. I do want to stress that it is still too early to make strong conclusions. And as I mentioned on the prior slide, there are a number of other things that are super important to account for that impact coronavirus outcomes beyond medicines that the patients are taking. One clear trend that we've seen is that more severe coronavirus outcomes are associated with the use of oral steroids such as prednisone or prednisolone. And all of the ways that we're able to model the data do indicate that there's a high that the patients taking prednisone or prednisolone are a higher risk group. That doesn't mean the patient should stop prednisone or prednisolone cold turkey. I really don't want to convey that at all. But I think as we're going through the weeks and months ahead, It will be important for patients and their physicians to figure out ways to manage inflammatory bowel disease, keep the disease in remission, that use medications that are steroid or prednisone sparing. About 40% of the reported cases were being treated with TNF antagonist medications. And so these are medications like infliximab, which is Remicade or the biosimilars, adalimumab or Humira, and there are a couple of other medications in that TNF antagonist class. And I think we can draw some reassurance that this class of medications does not appear to be associated with more severe coronavirus outcomes. And so for patients who are taking anti-TNF medications and probably a lot of the other classes of biologics, there really doesn't seem to be an early safety signal associated with these medications. Again, I think that overall this is reassuring. We do need more data and a bit more time before we can detect any medium or strong trends for other classes of medications.